Hi, this is Brian Kim. I'm going to share with you case number 48 in the Best Way to Do Cataract Surgery series. This is a moderately dense lens, and I'm going to perform double chop, cross chop, mechanical fracturing techniques, pulling pieces up out of the bag using the chopper, crushing the lens piece between the chopper and the phaco tip, emulsifying the lens pieces. This is a very controlled and systematic way to do cataract surgery. And so I'm going to use a cotton tip to hold the eye and center it. Use a corneal marker to help me center and size my rhexis. You can see there's a fairly dense PSC plaque there. I'm turning the eye downward and I'm making my paracentesis incision on the right side, which is superiorly. Turning the eye to the right. This patient does have a little bit of a upwards Bell's reflex, so I can take advantage of that and make my left paracentesis incision. I'm injecting some intracameral lidocaine and then some dispersive viscoelastic to coat the corneal endothelium and to flatten out the anterior capsule. This is triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, use the cannula to turn the eye towards me, and then go in. And that's the triplanar corneal incision. This is the puncture style capsule rhexis. I'm going to go into the incision very carefully, puncture the center of the capsule, pull it downward towards me, kind of teasing it towards me to create a little bit of a flap, grabbing the right side, trying to make sure that the flap is controlled, and then I'm starting to go around circumferentially, trying to follow the marks that I made previously to help center and size the rhexis. It's important to keep the teeth straight up and down to minimize viscoelastic egress. I'm going to go ahead and finish off the rhexis and burp some viscoelastic out. And this is a capsular fornix hydrodissection technique. I'm placing the cannula underneath the anterior capsular ridge on the contralateral side. Point the tip down, get a nice fluid wave, decompress. Oh, I'm seeing a little bit of iris prolapse here. So I'm gently burping the viscoelastic from the wound, just a little bit. And then I stop, and I'm asking for the intracameral epinephrine. Instead of further increasing the intracameral pressure, I decided to go ahead and inject some intracameral epinephrine, which will help stabilize the iris. I'm going underneath the viscoelastic and just pulsing the epinephrine. This does not really disturb the viscoelastic, it's fine. I switch back to the hydrodissection cannula, decompress on the left side, sweep the anterior capsule on the left side, turn towards the right side. You can see the lens spins nicely. I irrigate the surface of the cornea, lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuchal material, place the chopper underneath the anterior capsular ridge out to the equator, point the phaco tip vertically subincisionally, bring both instruments together, and this crushes the lens completely in half. This is the double chop. I place the chopper out to the contralateral equator, crushing it, pulling it centrally towards the phaco tip. This divides the right heminucleus. This is the cross chop maneuver. I'm using a little bit of vacuum to pull that first quadrant up with the phaco tip, and then I start crushing the lens piece between the chopper and the phaco tip into smaller bits, and then emulsifying the lens piece. I'm going underneath the second quadrant there with the chopper, pulling it centrally and then crushing it against the phaco tip. Again, this is another cross chop maneuver, and then I pull that piece up and then emulsify the lens piece. Going after the other piece of the second quadrant, first turning the lens to make it easier to get. And then I'm going to crush it with the cross-chop maneuver again, and then using high vacuum to position the lens, and then crushing it between the chopper and the phaco tip. Once the pieces are smaller, I'm able to emulsify the lens pieces. I'm going to turn the second heminucleus in front of me, place the chopper out to the equator, pull it centrally, and the phaco tip is deep in the bag. It crushes that second heminucleus completely. I place the chopper out to the equator again, pulling it centrally. I'm crushing that third quadrant, pulling up that fragment up out of the bag with the phaco tip, crushing it, and then emulsifying it. Using a little vacuum to pull that fragment up, crushing it between the chopper and the phaco tip, and then emulsifying the lens pieces. So this is the final quadrant. Place the chopper out to the equator, using a little vacuum to position the lens piece, holding the lens piece, crushing the lens between the chopper and the phaco tip, using successive mechanical fracturing forces, crushing the lens pieces. Once the pieces are small enough, start to emulsify the lens pieces. Whenever you have the last pieces, it's just very important not to be too aggressive with the phaco. And so I always keep the chopper deep, and I'm very ginger with the phaco energy with the last pieces. And then I'm using the phaco tip to pull up the epinuclear material. Again, I'm being very careful. Make sure the pieces come in without being too aggressive and keeping that chopper deep to protect the posterior capsule. Once all the pieces are out, I take the chopper out, push BSS in, take the phaco tip out, and switch it to the INA. I'm reducing the sleeve. It was a little bit too far away from the tip. I start subincisionally removing the cortical material from anterior to posterior. I'm sweeping side to side. You can see I'm getting occlusion. You always want to get occlusion before you start pulling, and that's the key. Once you have occlusion, then you can use mechanical forces to tease off the cortex. And that's what I like to do, teasing it off. I really like to do it in a combination of using the high vacuum as well as pulling and teasing off the cortex from the bag. So I switch to the polish mode, and I'm starting to polish underneath the anterior capsule edge, polishing the lens epithelial cells, and then I'm polishing the posterior capsule surface as well. So I push BSS through the paracentesis into the subincisional capsular fornix to make sure there's no hidden cortical pieces. It looks fairly clean. And then I switch and inject some cohesive viscoelastic to fill the capsular bag. And then in the other hand, I'm using the capsule sweep to, again, further polish underneath the anterior capsule edge. I don't really go into the capsular fornix. In the beginning, when I started sweeping, I thought that I had to do that. But I think really, because it's really a blind procedure, past where you can see, it's not worth accidentally traumatizing the uveal tissue in order to sweep into the fornix. And so I really limit the polishing around the anterior capsular rhexis edge. So I inject a single piece of acrylic intraocular lens into the capsular bag. The leading edge is in, the trailing edge is out. I go in with irrigation, and I disengage the leading haptic and then trailing haptic, go underneath the optic, tilting it and rotating it 90 degrees clockwise. I'm evacuating the bag of the viscoelastic, making sure I'm directly removing the viscoelastic with my technique. And then I'm polishing again underneath the anterior capsular rhexis edge, because oftentimes there's a bunch of stuff underneath there, some lens material mixed with viscoelastic. And in the process now, I rotate the haptics into a horizontal position. Once I feel good about the lens position, I removed all the viscoelastic. I'm removing all the viscoelastic from the anterior chamber. Pulsing the angle with the cannula, making sure there's no hidden viscoelastic, and then I hydrate my incisions. So again, this is a moderately dense lens. You can see this is a fairly routine technique for me, double chop, cross chop, and then utilizing mechanical fracturing forces to crush the lens and divide the lens, leveraging the use of the chopper as an instrument that can really manipulate lens pieces and prolapse pieces up out of the bag. This is really, in my opinion, the best way to do cataract surgery. It's very controlled, it's very systematic. I don't tend to run into trouble. I don't have to worry about accidentally traumatizing the posterior capsule. All the crushing forces are performed without using phaco energy or high vacuum. So that's why I feel like it's a really very safe and controlled situation, especially when you have loose bags, small pupils. It's really very advantageous not to have to rely on high vacuum in those situations. Unfortunately, when you have tough cases, we tend to use more vacuum and ultrasonic energy. And that's when really I feel like it can be a little bit of a liability. So this way, you don't really have those same issues. And so I do feel like this is a really great way to do cataract surgery. And I hope this was helpful to you. And I thank you for your attention.